All right. Well, why don't we get started? Good morning to everybody. It's already 7:02. It's a real pleasure to introduce Shanae Price, who's a colleague of ours in physical medicine and rehabilitation. He did his residency at UM at PM&R, and a pain fellowship here as well. And he currently works with us in the Brain and Spine Clinic at UHealth Tower. He has a lot of different roles in the department. He's vice chair. He's the head of the residency program, and a valued colleague on a national front. He's director of neuromodulation in the American Academy of PM&R. So lots of different roles. Great colleague. And we're looking forward to hearing his talk on essentially conservative treatments of back pain, right, Shanae?
Yes, sir.
Perfect. Thank you.
All right. Thank you guys for having me. I'll try to keep this as concise as possible and allow you guys to have some time at the end to answer some questions. Alan or Dr. Levy asked me to kind of speak about conservative management options that we have for those perioperative patients. Those are patients either prior to surgery or immediately following surgery. So kind of want to just give a quick overview of what we offer from a physical medicine and rehabilitation standpoint and from an interventional spine pain management standpoint. So now we'll go ahead and get started. As I was saying, globally, chronic back pain has been estimated to have a prevalence of 4.2% in individuals that are aged 24 to 39%. 39 years old, and 19.6% in those aged 20 to 59. That's kind of just stating that, how prevalent it is and what we see on a regular basis. Kind of from a PM&R standpoint, we look at low back pain as either below the waist or above the waist. That's kind of one way that that did not play. And that's kind of the way we can look at that. So below the waist, back pain is typically seen as, musculoskeletal pain, piriformis muscle, sacroiliac joint, and then above the waist, we're thinking more facetogenic type of pain, also radicular pain, discogenic pain, things of that nature. So I place this up there so you guys can see kind of the anatomical landmarks that we're looking at. You see the PSIS indicating where the pain is, and then the facet joints also just above the red line, which is the waistline. And then we also have those patients that have the radicular symptoms, as we know, classically radiating down to the lower extremity, electric-like sensations, so on and so forth. So we'll start off talking about sacroiliac joint pain and kind of what we do to identify sacroiliac joint pain, how prevalent it is, and things that we can offer for patients as treatment options. So with sacroiliac joint pain, it's very prevalent, showing that 10 to 27% of mechanical low back pain is secondary to sacroiliac joint pain. Sacroiliac joint pain can come from a multitude of etiologies, including, some patients that have undergone surgery that have hypermobility of that sacroiliac joint. Also, females that have been releasing relaxin or oxytocin can also cause relaxation of the posterior sacroiliac joint ligaments, and that causes hypermobility, which leads to some inflammation in that joint. Also, there's leg length discrepancies that can lead to hypermobility of the sacroiliac joint, and then just in general, obesity and any obvious asymmetry in their anatomical gait pattern can lead to some sacroiliac joint dysfunction and inflammation. So we try to identify those patients, and I'll give you a quick overview of the anatomy of the sacroiliac joint just as a review so that you can understand why I choose the procedures that I choose and what makes them valuable. So we see here the sacroiliac joint right over the PSIS. I'll identify it on the left. It is a diarthroidal joint with cartilage just like any other joint in the body. We notice that posteriorly there's a capsule that covers the joint, and that is what creates that synovial joint that we're speaking of. Within that joint, normal cartilage, things of that nature. And so there's also the nerves that innervate the sacroiliac joint. The thing about the sacroiliac joint is that once you're able to access the joint, what are we injecting and how is it helpful for the patient? So obviously, if there's an inflammatory component, which most of the time that's what we're treating, we want to inject corticosteroids there. And so The corticosteroid of choice that I use is Depo-Medrol. It is a particulate steroid that has been shown to be highly effective in the sacroiliac joint. Also, you have to consider what type of local anesthetics you're injecting into the joint. So many of the local anesthetics are very chondrotoxic. So while they give some short-term benefit for every patient, long-term, they're going to cause damage to the chondrocytes and obviously be causing damage to the cartilage. So long-term, that's not going to be very helpful to the patients. There's been several studies that have shown that ropivacaine, 0.2% in low volumes, is not as chondrotoxic, is the least chondrotoxic of all of the local anesthetics. Therefore, every time I do a sacroiliac joint injection, I'm only injecting 0.5 mLs of ropivacaine along with my steroid, and then majority of it's going to be saline. And then I also bathe the posterior sacroiliac region because, as we know, all of the sacroiliac ligaments attach to the PSIS, and that's where that's tender. And that's typically because most of your inflammatory markers, the phospholipase A2 and things of that nature, are all located in that ligament. And that was done by a study done by Bogduk, one of my favorite anatomists. So that's kind of just an overview of why I choose that area. Then there are also patients that have such hypermobility that they no longer respond to intra-articular sacroiliac joint injections. And for those particular patients, we're also able to do some lateral sacral branch blocks, which provides innervation to the joint. If you remember from the anatomy slide, there's also an anterior joint capsule. And unfortunately, the posterior sacroiliac joint denervation techniques that I utilize are not able to capture pain that comes from the anterior joint region. So that's why we kind of hold it back and we use it as a last option for those patients that have persistent sacroiliac joint pain. We can see that the sacroiliac joint ligament and the sacroiliac joint are innervated by the dorsal rami of L5 all the way from S1, S2, S3, and S4. It can present sometimes like a lumbar radiculopathy or facet-mediated pain. Typically, we don't see this pain radiating down below the knee, but there have been cases documented where it does radiate below the knee. Obviously, after we do a diagnostic lateral sacral branch block, we would proceed with the radiofrequency ablation if the patient obtains greater than 80% relief of their symptoms with that diagnostic block. Next, we're going to talk about the Z joints or facet arthropathy. So this is very, very prevalent. I get a lot of referrals from providers to evaluate patients for facet arthropathy. As you can see, it contributes up to 90% of cases of patients with axial low back pain. The issue with facet joint arthropathy and diagnosing it is that it can be very confusing. So as you can see, various studies have shown prevalence ranging from 4.8% to 84% when you combine all the factors of history, physical examination, radiographic findings, and then diagnostic injections, which will include both intra-articular facet injections as well as diagnostic medial branch nerve blocks. Looking at the Z joint, it is a true synovial joint. So it still has the articular surfaces covered with the hyaline cartilage, and it contains a fibrous capsule. So that means that it has a volume capacity. So while we do some intra-articular facet injections, which we'll go into a little bit more in depth in just a bit, we noticed that in the lumbar spine, that joint can hold anywhere from 1 to 1.5 mLs, and in the cervical spine, even less at 0.5 to 1 mLs. The innervation of every facet joint is going to be innervated by the posterior ramus, and that's going to lead to the medial branch, which is what we use to block for a diagnostic procedure. That particular nerve is going to innervate the Z joint, the multifidi muscles, the intraspinal muscle ligament, and all those posterior structures that we are able to palpate sometimes when we see a patient and they have that tenderness of palpation just lateral to the spinous processes. There's been evidence that's shown that that's pretty much the most predictive finding that we found on physical exam that points to facet arthropathy when you couple it with the history of the patient as well as the physical examination. So here's just another quick video to kind of overview the anatomy of the facet joint. So we can see here the facet joints are the ones that we're lighting up here as being in pain. you'll see that there is a capsule that surrounds the facet joint, and that plays a very important role in why we choose the treatment options that we do. Obviously, for every patient, we always value physical therapy and patients just being active. That's going to be the most helpful thing for us, but that's the posterior facet capsule there. Then we also see where we have our medial branches that innervate the facet joints. Each facet joint is going to be dual innervated by two medial branches, one from the level of and one from the level below, from the level above. So we can see that indicated here in the blue. So a lot of times that's what I'll focus on when I do my diagnostic medial branch blocks, and I'll go through some of the details of that. The other cause of facet joint related pain can be hypertrophy of the mammo-accessory ligament, which I'm indicating or simulating here with the black line there. And you can see that when that gets ossified, sometimes it can cause compression of the medial branch, and that can simulate facet related pain. So mechanisms of injury for facet arthropathy, a lot of times it's due to repetitive strain or low-grade trauma or any stress from degenerative joint disease or degenerative disc disease, because that obviously causes more compression on the posterior elements. There's also adjacent level disease following anti-fusion because we have increased mobility of those particular levels, those particular facet joints. On physical exam, the lower facet joints experience more strain with contralateral bending, and that would be the L3 to L4, L4 to L5, and L5-1 facet joints, and as well as with forward flexion. You don't see so much strain on the upper joints with the forward flexion. So higher Z joints experience more strain with ipsilateral bending. That would be T12 in the upper facets. And then again, just to point out that the tenderness to palpation over those paraspinal muscles innervated by that dorsal ramus has been the most consistent finding on physical exam when we couple that with the diagnostic medial branch nerve blocks. So the referral patterns are very inconsistent for facet arthropathy, and I'll have a diagram later that will show kind of the referral patterns on each patient. So how does the patient present clinically? Well, let's look at some of the studies that have been done, even from back in 1988, that looked at diagnostic blocks, both intra-articular and medial branch nerve blocks, and how those patients responded. So the patients that responded the most were patients that had pain localized to the back, referred either to the anterior thigh or hamstring region. They also had the paraspinal tenderness to palpation, and reproduction of pain with extension and lateral rotation. That would be ipsilateral rotation and facet loading on that side. So pain radiating below the knee was actually a negative predictor because we can have concomitant discogenic pain causing some type of radicular symptoms with facet arthropathy. And when we treat the facet arthropathy, we notice that those patients do not respond nearly as well. So we have the diagnostic blocks, which is, as I was stating, and they have done some trials to compare diagnostic medial branch blocks versus intra-articular facet injections. So they've been equally effective on two of the studies that I looked at. Basically, there was no difference in those patients at 1 month. But interestingly enough, we noticed that they only used local anesthesia for the diagnostic medial branch nerve blocks. And for the intra-articular injections, they went inside the joint. They used steroids coupled with the local anesthetics. Now, obviously, I believe that is a strange study to do because we don't do a diagnostic medial branch nerve block for long-term therapy. We're doing that to see if a patient can obtain greater than 80% relief of their symptoms. And if they do, then we proceed with a radiofrequency ablation, which we will discuss a little bit later as well. So with that being said, I'll talk a little bit about why I choose the diagnostic medial branch nerve blocks over the intra-articular facet injections. And that's simply because up to 20% of patients can have the ossification of the mammo-accessory ligament. And so if that is the cause of the patient's symptoms and we're simply putting steroids into the facet joint, it's not going to provide them that long-term relief that we need to provide them. We need to be able to identify that blocking that medial branch nerve is going to provide them with significant relief, and then we can proceed with the radiofrequency ablation that has been shown to provide efficacy for anywhere from 6 to 18 months. This is again that lumbar facet pain referral pattern. The anatomy that you can see here is, and as you can see, it's very inconsistent where we're able to identify the referral patterns for patients with facet arthropathy or facetogenic pain. So we choose patients for diagnostic medial branch nerve blocks after they've completely failed conservative management. So that would be some type of oral medications to try to address the issue, as well as a full course or at least an attempted course of physical therapy to kind of strengthen the core and the spinal muscles surrounding the facet joints, as well as the paraspinal region. And so that's going to help patients to perform better and respond better to diagnostic medial branch nerve blocks. Typically, the form is going to state that I will perform the first block with a lidocaine 2%. And again, I will use 0.5 mLs at each level to specifically keep that local anesthetic localized to the medial branch nerve and not to spread to adjacent structures and kind of falsify my results. If the patient gets a significant improvement, then I will proceed with a second block using bupivacaine. The reason why I use the different local anesthetics is to determine how long does the patient have relief of their symptoms. So typically with lidocaine, we're looking anywhere from 1 to 3 hours, and typically with bupivacaine, we're looking anywhere from 6 to 8 hours. Obviously, that's different for each individual based on how quickly they metabolize the medication. But most importantly, I just want to make sure that they get longer lasting relief with the second block. So then obviously if they respond well to that, we'll proceed with the radiofrequency ablation. Now let's identify those candidates that don't do very well with treatment. And those are patients that are currently on opioids, those that have had previous surgery. And I've had discussions with my neurosurgery colleagues. A lot of times we go away from facet injections, especially at the level of a fusion, just simply because there should not be much mobility at that level, and that facet joint should not be what's causing the problem. We'll get into more details about what we think can be causing low back pain following a surgery, especially a fusion. And then obviously those patients that have had multiple RFAs are not good candidates either, simply because after we perform the radiofrequency ablation, those patients typically have sprouting that comes back. And so that medial branch now becomes several sprouts innervating that joint, which are very difficult and challenging to target. To kind of account for that, I'll show a video of the device that I use for my radiofrequency ablations, and it's called the Venom. It's a Stryker product, and then you'll see on the video why I choose this device to give me a larger surface area to perform the ablation. So in summary, for facet-related pain, kind of my take on this is that we really have to focus on the patient history, the physical exam, and along with the image findings to come up with the truth and try to figure out how to best treat these patients. So now we'll move on to epidural steroid injections, which we also get a lot of referrals for those. So most epidural steroid injections are performed for radicular symptoms. Steroids are focused to the area of inflammation to minimize the neuropathic symptoms experienced by the patient in hopes of allowing the underlying pathology proper time to heal or to improve. whether that be following a surgery or prior to a surgery. Our goal is to minimize their symptoms so that they can, be more active. Again, strengthening those core muscles to try to give that disc time to reabsorb or that underlying pathology time to resolve. We found phospholipase A2 neuropeptides such as substance P, vasoactive intestinal peptide, and calcitonin gene-related peptide that can be released from an injured nucleus. That increases local concentrations of those neuropeptides and are thought to sensitize the free nerve endings, generating painful discharges and producing back pain. It's also likely that these neuropeptides sensitize the adjacent nerve root and the dorsal root ganglion, generating the nerve root symptoms. So typical indications for epidural steroid injections would be for radiculitis, disc herniations, annular tears, and spinal stenosis. So I'll go through a little bit about the anatomy here and the epidural space. The anterior compartment of the anterior space is going to be composed of the anterior border being the vertebral body, the intervertebral disc, and the posterior longitudinal ligament. And posteriorly, it's going to be bordered by the thecal sac. Posteriorly, that space is going to be bordered anteriorly by the thecal sac, and then posteriorly by the ligamentum flavum and the laminae. It's important to know that the posterior epidural space in that area is about 5 to 6 millimeters when you look at the lumbar spine from L2 to L5. So a lot of times I get questions, which do you choose? Do you go with caudal epidural steroid injections? Do you go with intralaminar epidural steroid injections or transforaminal epidural steroid injections? So we'll kind of take a look at the anatomy, and I'll tell you why I choose what I choose more frequently. So looking at the picture on the image on the left, that is indicating a caudal epidural steroid injection, which is great for those patients that a transforaminal or an intralaminar may be challenging, technically difficult, but we can use a larger volume of injectate in that region. Up to 15 mLs is often used, majority of that obviously being saline to help to transport the steroid to the affected levels. They've shown that injecting 5 mLs of contrast can spread all the way up to L3 in this case. Obviously, that's in an ideal situation where we're not dealing with much canal stenosis or fibrosis in the canal. And then you see the intralaminar technique where we'll take a midline approach, kind of going through the ligamentum flavum to access the posterior space of the epidural region. And then in that area, we are also able to inject the steroid with either local anesthetic or normal saline, also a larger volume than you can inject than using a transforaminal approach. Also a preferred approach if a patient is unable to discontinue anticoagulation, things of that nature, along with the caudal epidural steroid injection. So I'll kind of show that and that approach with that. This is just what we kind of just discussed. And the injectate should always flow upward towards the lower lumbar levels in that case. We also do the same approach for a cervical spine with an intralaminar approach there. But again, the needle is staying focused in the posterior epidural region. So if you have any anterior pathology, it's going to be challenging to get that. So this is, again, just talking about the intralaminar approach, taking that midline approach that I discussed. And the paramedian approach avoids that interspinous ligament and goes through the paraspinal muscles. This is just taking a look at the foramen. This is the lateral view of the foramen, and we can see kind of the borders of the foramen, what types of pathology and things can affect the nerve root that is exiting through the foramen. We see that the nerve root exits just above the disc at that level. So if we're looking at L4, L5 disc, we should be seeing that L4 nerve root exiting at that foramen just above that disc. So we know that that's the reason why those lateral disc herniations can be so problematic for patients and lead to an L4 radiculitis. But we all know also that typically when you see a patient, it's a little bit vague, always not very clear cut which nerve roots are being affected. And typically that's because disc herniations can also affect the descending nerve roots. And so a lot of times we really have to pay attention to what the patient's presenting like, where they're complaining of their symptoms. Take a look at our imaging, and then we can try to target that particular area based on all of those things in conjunction. So it's just outlining that foramen there again. And We'll look at the anterior border, obviously, is by the vertebral body, the intervertebral disc, as you can see in the top upper left picture. And I've indicated that the red portion there is some sort of disc herniation or disc extrusion, obviously causing compression over the spinal nerve. And then you can see posteriorly any type of facet hypertrophy, which I've indicated with some osteophytes there over the facet that can also cause or create some type of nerve root compression or irritation. With those patients, it's a little bit easier to focus on the area of concern and the area of compression and directly where that inflammation is if we take a transforaminal approach to go right into that area. And I'll show you that in the next view. We see a similar situation with the cervical spine, where the disc are anterior and obviously a posterior disc herniation is going to cause inflammation of that nerve, as well as with facet or uncovertebral joint hypertrophy, which is just anterior to the nerve root. So when we talk about a transforaminal approach, as you can see exactly where we place the needle, it's in very close proximity to the underlying pathology. So that is why that is the approach of choice for myself. I also do something that's not widely used here at the university. So there's a very good study that compared the use of 8 mLs of injectate compared to 3 mLs of injectate. And I know sometimes when I say that I'm able to inject 8 mLs in the foramen, people's eyes immediately open up. But the study showed that obviously the 8 mLs was much more effective for patients, both in the short term and the 6-month outcomes as well. So typically what I do is once I have the needle placed in that area and around the foramen and confirm that I'm in the epidural space with injecting a very small amount of contrast, I will give anywhere from 0.5 to 1 mLs of a local anesthetic to help decrease the sensation of pressure around the dorsal root. And then I will proceed to inject very slowly the 7 mLs of the steroid mixed with normal saline. And so that is kind of my approach there. And we've had very good outcomes from our patients. And we take a very slow time. Every now and then patients aren't able to tolerate that amount of volume. And obviously in those cases, I indicated in my note that we had to hold back on how much we injected into the foramen due to the patient not being able to tolerate that. So we're also looking at, I use a subpedicular approach. And so with that approach, it's less likely for me to contact the nerve itself, but also there's higher risk of intravascular injections. And so for that reason, we make sure that we follow the ASRA guidelines for anticoagulation medications and when patients should stop taking those medications to minimize those risks of developing a hematoma. So let's look at what some of our colleagues have looked at. Matt Vicar looked at patients that were undergoing transforaminal epidural steroid injections, obviously to disc herniations, and 70% of those patients were at least 50% better at least at 1 to 2 months. And then 40% of those patients are better at 12 months. So up to 30% of those patients experience complete pain relief. And working with you guys in the neurosurgery department, I'm the type of person that I don't want to continue to do things that are not being helpful for the patient. So anytime I try an epidural steroid injection that you guys may send over to me, I'm going to talk to the patient, obviously right after the procedure, see how they responded to it. I try to indicate as many details as possible in my notes so that you guys understand how the patient has responded. And then from there, I have my nursing staff contact the patient 3 days after, just to see kind of how they're doing. Based on their response to that, I may send you a message and say, hey, would you like to proceed with another injection to get the patient more long-term relief? Or would you like to just see the patient back because they would possibly be a surgical candidate? We use those transforaminal epidural steroid injections for both diagnostic and therapeutic purposes. Focusing on that particular level, we're able to identify if that provided the patient with any relief at all for that particular time period. We can kind of focus on that with the surgical approaches that you guys take. I also perform some purely diagnostic procedures where if requested, if you need a selective nerve root block, I just take a little bit of a flatter approach to make sure that I keep the contrast and the injectate around the dural sheath surrounding the nerve. And for that, I just inject local anesthetic anywhere from 0.5 to 1 ml just to identify that as the problem of concern. There was another systematic review, not a very good systematic review, but there aren't very many good papers, obviously, because of different techniques, different volumes, different medications that people are using. But it did show that transforaminal epidural steroid injections were superior to placebo for treating radicular symptoms. And so, again, it's something that we can use to help patients either prior to surgery or to avoid surgery if possible, and then also following surgery to treat kind of adjacent level disease. But it is superior to intralaminar and caudal injections for radicular pain, especially when we can identify a particular level or two that we want to focus on. So now let's move on to get a little bit more progressive here. And I put this side here because I don't really understand why they use the terminology of failed back surgical syndrome. I think it's one of the worst names that we could have possibly picked for medicine or in medicine, because I don't consider patients as a failed back surgical patient. But unfortunately, that's just what the insurance companies require us to use to name this etiology. But it's more so, as we know, patients typically get better for some period of time, and then they may have a different type of symptom, whether it still be low back pain, but just from a different etiology or return of some radicular type of symptoms. But then we get imaging, and we notice that there's no nerve root compression or anything of that nature. But sometimes we do see some fibrosis in the epidural space, and typically that is the cause of patients with failed back surgical syndrome. So between 1998 and 2008, the yearly number of lumbar fusion surgeries performed in the United States increased significantly, as you can see, with the total number of spine operations exceeding 1 million far back in 2002. So I'm sure that number's gone up significantly since then. The overall incidence of failed back surgical syndrome was estimated to be 10 to 46%. Now, how do we go about treating failed back surgical syndrome? A lot of times we are not as aggressive as we could be. I know that some of those patients are not candidates for an additional surgery or extension of their fusion or anything of that nature. But a lot of times you'll see those patients immediately started on something like opioid medications, given an extensive course of physical therapy. But we do have other options that we can treat our patients with that have had very successful outcomes when we choose the patients appropriately. So the options that we can offer the patients would be neuromodulation or spinal cord stimulation. So it's a completely implanted system. We do have some of my colleagues in the department that do implant the paddle systems. I also implant the percutaneous leads into the spine, and I'm able to test and during the 1 week trial that we have for the patients, we obviously speak with the patients on a daily basis. We make adjustments for the patients. It's similar to an epidural. Obviously, we just place the leads into the epidural space, typically at the T7 to T9 region. But obviously, we have to adjust that based on the patient's pain patterns. And then we turn the device on and we make subtle adjustments throughout that trial period to make sure that the patients can improve their functional status throughout the trial. We also do spinal cord stimulators for the cervical spine for any patients that status post ACDF or any type of cervical surgery with symptoms radiating to the upper extremities. There's a variety of different companies that I use for spinal cord stimulation, and I'm very selective with those companies based on the products that they offer and also the desires of the patients. So some of those devices that we use are rechargeable devices, and some are primary cell, which do not require to be recharged. And some are MRI compatible, others are not. Some of the leads or the paddles are MRI compatible, and others are not. So we're very selective with who we choose when we want to proceed with any type of spinal cord stimulator trials. So this study is very interesting. It's the SENZA trial. Basically, they looked at a randomized control study or trial for the efficacy of spinal cord stimulation. They looked at 198 patients. 86% had previous back surgery. 88% were currently taking opioids at that time. And positive responders were seen as any patient that would have greater than 50% reduction in their pain. So at 3 months, we saw that 85% had reduction in their back pain, 83% had reduction in their leg pain, which is pretty greater than 50% reduction in those pains, in those painful areas. And then at 24 months, we saw a slight drop in that number from the 85% to the 76% in back pain, and then 83% down to 73% in reduction of leg pain. Now, a lot of that had to do with, we are constantly learning about neuromodulation. We're adding more techniques, different programs for patients. And so a lot of times when patients lose efficacy or they have a dip in the relief of their symptoms, it's typically because we're not programming them properly. So we just reprogram those patients and they typically do better.
Hey, Shanae, it's Alan. Just real quick question, because
Yes.
We've seen trials in spine surgery for, discogenic back pain, for example, that have come out that, report 90% improvement rates, et cetera. This particular trial, who is it funded by?
So this is a Nevro trial?
So it's a company-based trial.
Yes. All of them are industry funded trials, unfortunately. But I'll talk a little bit later about my own personal experience and numbers. I think a lot of it has to do with patient selection and also, accompanying them, putting them with the right company to have good outcomes. And a lot of times, that makes a world of difference.
Thank you.
Yes. So we looked at also how clinically relevant is this, the cost effectiveness of spinal cord stimulation versus med management. And then you can see the data here showing that it's more cost effective for utilization of neuromodulation as opposed to oral med management. Also just better overall for the patients if they are a responder to neuromodulation. Obviously nothing in medicine is 100%, but if we are able to capture that patient and prevent them from being on chronic opioids for treatment of their low back pain or neck pain following a surgery with adjacent level disease, that's going to be a little bit better and more beneficial for the medical system overall, the healthcare system overall. So we looked at these costs, and you can kind of see here that a large amount of patients saved a lot of money and less of a load on the healthcare system. And then 15% of those patients actually returned to full duty at work, which is not extremely high, but it is something that's better than obviously 0% returning to work after they presented with these sorts of complaints. So how are we helpful for our patients? So in UMPMNR, which I'm the only one currently doing trials and implantations of these devices, we have 86% success rate. So compared to the national average, we're slightly better. National average is 82% when you talk about successful trials converting to permanent implants. And they would have to keep that device in for at least 1 year to be considered successful. And so we're at 86%. We have had to revise 3 systems. One was not implanted by us. It was implanted at an outside facility. Sometimes the systems need to be revised primarily for lead migration. And that's sometimes just because the anchor system may fail us. And so we have to go back in, replace the leads and re-anchor them down so that they aren't very mobile. The outcomes at 24 months for my patients is 79% of patients implanted reported greater than 50% improvement of their symptoms, and 75% reporting improvement in their function, which I think is very, very important. I do work, again, as I was saying, with multiple companies using different devices. Many of those companies have now progressed to the point where we're able to get live data. So they follow up with patients via phone calls. Whatever the patient reports to them, they store in their system, and they're able to pull that data up at any time for us to review. So this is the most up-to-date data. I just actually got it from my 3 representatives late October to prepare for this presentation. So overall, when we choose the right patients, obviously we don't want to just stem everybody and anybody, but when we do take the time and discuss the expected outcomes with the patients, we're able to do pretty well with using neuromodulation to treat low back or leg pain or neck and upper extremity pain. So with that being said, I would say whenever in question, before we say, oh, we're just going to start you on these opioids and see how you do over time, because as we know, it's very challenging to decrease the opioid use in patients once they've been started on it, especially after they've been on it for 3 months or longer. I would say that it's perfectly reasonable for a spinal cord stimulator trial to see how they respond to that, and then obviously if they respond well and we're able to improve their function, that's a great outcome. Any other questions about that, Alan?
All good, thanks.
Okay. So Dr. Levy also asked me to kind of present to you guys about how to get patients over to our department and kind of what we do. So Department of BMR, since I started and became the outpatient medical director, we've really focused on how to streamline patients and get them to the appropriate providers. And so there are 3 providers in our department that do minimally invasive procedures, such as all those that I've mentioned. I'm the only one, obviously, with the that does neuromodulation, but we all do the cervical, lumbar, thoracic injections. I am also the only one in our department that does the radio frequency ablations, but Dr. Sherman and Dr. Irwin do intra-articular facet injections at all of those levels. So in terms of referrals for particular procedures, you can always refer directly to myself, Dr. Sherman, or Dr. Irwin. And I have spoken with Irene. I've given several presentations to the nursing staff as to how to get those referrals directly over to us. They can enter that order directly into the system for you guys, and they will get sent to our procedural scheduling department. We typically get those patients in pretty quickly. I've increased the amount of time that I spend doing procedures due to the high volume of patients that we're receiving referrals on. From a conservative management standpoint, that's those patients that you're seeing in clinic, and they may not be indicated for surgery or for procedures at that time. It may just be a patient that will respond very well to physical therapy and kind of keeping a close eye on those patients to help them to improve their functional status without ever placing a needle in them or cutting them at all. And so those providers that we have are Dr. Alessia, who focuses on spine and MSK pain. He also does EMGs. Luva Rodriguez, who is our nurse practitioner. She focuses on spine-related pain. You'll also see her with me a lot in the spine and brain clinic. Dr. Sherman, as you guys have known for quite some time, focuses on spine and musculoskeletal pain, and he also does EMGs. Then you have Dr. Irwin, who also focuses on spine and musculoskeletal pain and does EMGs as well. So whenever you're in doubt, you can always reach out and just place a referral. That's REF 288, or just a referral to physical medicine and rehabilitation for evaluation and treat. If you don't know, which procedure should I pick? Who should I send this patient to? Just put in that referral for physical medicine and rehabilitation. And behind the scenes, we have a trained clinical business operations team who does a very good job of placing that patient with the appropriate providers. Obviously, if there's a patient of high importance or someone that you think that I need to see myself sooner rather than later, I'm always open to either send me a text or send me a message in UChart or send me an email. I do my best to kind of respond to you guys as quickly as possible and get those patients expedited for their visit. And if it's not a patient that we feel will benefit from seeing me, I'll take care of that triage process. So there also, we have the direct referral process for the procedures through Maritza Brown and also through Daniel Hernandez. But those, obviously, as you guys know, employees change all the time. And so with that being said, if you want to just reach out to me directly, that's perfectly fine, or to the clinical business operations team, which Irene will have that access to be able to help you guys out. So I wanted to open it up for any questions that you guys may have about anything that we discussed in the presentation. I know we kind of went through a lot of different things pretty quickly. You guys already understand the anatomy. Now you kind of understand the conservative approach that we take to treat these patients in the perioperative time period. And so I wanted to open up the floor for that. Also, any questions that you guys may have about placing referrals for PM&R and how to expedite patients being seen by our department.
Hey, Sinead, that was a fantastic talk. Thank you. I got really 2 quick questions, and then hopefully my colleagues will pipe in as well. So the first question, you briefly touched on anticoagulation and procedures. And so our patients could be on aspirin, Plavix, Coumadin. And so what is your view in terms of stoppage of these different medications, like the top 3 or 4? How long before the procedure do you want the medication stopped, starting with the simple stuff, aspirin, then Plavix, then Xarelto, and then Coumadin? Maybe take those 4. And then
Sure.
the next question is, there's patients that we see, or I see, the only thing I know is that they're clearly non-surgical and I have nothing to offer them. And I'll want to send them to PM&R and take over the patient and figure how they can help them. But then there are other patients who are clearly surgical and we just want a diagnostic block, and we'll just say, can you do an L4-5? Transforaminal injection in preparation for possible surgery. For those 2 different sets of patients, do you still, for the first one, obviously you need to do an assessment to figure out what to do or if to do anything. But in the second set, do you obviate sort of having to see the patient, or can we just go right to the procedure? Because that would fast track the patient as opposed to having 2 visits, et cetera. So if you could take those 2 questions.
Sure. So overall for anticoagulation treatment, I go by ASRA guidelines. My entire staff, nursing staff, nurse practitioners all have those guidelines accessible. They kind of makes a difference on which type of procedure we're doing, the comorbidities of the patient. But in general, when you talk about things like aspirin, it's anywhere from 4 to 6 days, depending on if it's primary prophylaxis or secondary prophylaxis. So I'd say you're pretty safe if you go ahead and let the patient know that to discontinue this medication for 6 days prior to the procedure, obviously if cleared by the prescribing provider. Also, when we call the patient to schedule, we go through that list with the patient. We make sure that they have stopped taking those medications for the appropriate amount of time. For things like Coumadin, Plavix, less time because it doesn't take as long for them to lose their anticoagulative properties. So we're typically 24 to 48 hours on those medications to stop them in general for the spine procedures that we perform. Now, talking about referrals, for those patients that you think are not surgical candidates, you think would benefit from more conservative management with our department. Yeah, for those patients, as you know, you guys can always send them over to us for evaluate and treat. We just ask that sometimes in your documentation, it may not be very clear exactly if you want us to kind of continue to treat the patient, or if you want us to treat the patient and then send them back to you in 3, 6 months, 12 months, whatever the case may be. So sometimes we're a little bit in limbo. We don't want to hold on to the patient, but if the patient's doing well with conservative treatment options, we may just say, okay, follow with us. Obviously, if they start to fail those conservative options, we want to be able to send them back to you guys and indicate, hey, we tried X, Y, and Z, and they didn't respond very well to that. So we think they may be a surgical candidate at this time, and let you guys kind of determine and have that conversation with the patient. And then for the final patient is those patients that you believe that are surgical candidates, and you just want to kind of do a diagnostic and therapeutic block, or maybe buy us some time to get the patient scheduled for the surgery. Those can be direct referrals, of course, for those procedures. Just clearly state what levels you want us to perform the procedure at, and I'll take care of those patients. It's a lot easier for us if we're very clear with where we send the referrals to. So for the procedural scheduling team, if you send those patients directly to them, then they'll be able to get those patients in pretty quickly. A lot of times what we see is that we're sending the evaluate and treat patients also to that same scheduling team. So they kind of have to weed through all of that and figure out which patients they need to prioritize. And then they have to then go back and send those patients to the actual referral department so that they can be seen to be evaluated and treated. So that's a process that I'm working through with the staff and with Irene especially to try to expedite that and figure out where to appropriately send our patients.
Thanks.
Yes.
Hi, Jane. This is Joe Gracioli. Thank you very much for the great presentation.
Hey, Dr. Gracioli.
I'd like to hear your thoughts about different ways to stimulate the spinal cord, meaning between burst DR, TDM. How would you choose different paradigms for different patients in the topic of failed back surgery syndrome, which is commonly the most indication?
Yeah. So, yeah, I mean, that's a pretty in-depth study, but in general, I go based on the data. And high frequency right now has shown to be superior when patients have kind of a peripheral neuropathic type of component. So any type of radicular symptoms, they've responded very well to 10,000 hertz of stimulation with the long-term data. So they have a very good study out that shows that 24 months out, they've maintained that level of pain relief or symptom improvement. So oftentimes when that is the primary complaint that patients are having, that'll be the method of choice for that. Then you look at companies like Abbott who offer the Burst DR. And so I think those have also been very helpful for patients with low back pain. They're pretty comparable with all the other companies, including Boston Scientific and Medtronic, for treating axial low back pain due to failed back surgical syndrome or post-laminectomy syndrome. And then you can look at Boston Scientific, which I like because of their contour programming. It's able to individualize the type of waveform, the type of therapy that we're able to give to each individual electrode. And so with them, they have the 16 octrode lead. And so we're able to individualize their therapy if they like paresthesia based versus paresthesia free at different areas of their lower extremities or in their back or in their neck even. We're able to personalize that therapy. So that's a presentation in and of itself, Joe, and I can definitely have that conversation with you, but that's kind of my approach to it.
Thank you, Jim.
No problem. Any other questions?
About the restorative stimulation. About restorative stimulation, like this new system that's on the market now for L2 stimulation to rehabilitate the multifidus. It's a different concept. It's not spinal cord stimulation. It's more for muscle related. Have you had some experience or good experience with the Reactivate?
I haven't used it myself. I've been reading up a lot on it. It seems pretty promising, but obviously I think it needs to stand the test of time. We need to have more numbers involved with it, and we need to kind of see more which type of patients are they actually focusing on. So I think that we can provide some stimulation to the multifidi muscles to help patients to improve their functional status and decrease their symptoms, but at what cost, right? Because we have to stimulate it at a much higher frequency with much larger waveforms to involve the motor units, and oftentimes over time that can cause a reverse type of pain on stimulation of the painful fibers, the alpha and beta fibers. So we kind of want to avoid that while balancing stimulating just those motor fibers. So I think it's also going to matter where we place those leads. Far more lateral than over the dorsal columns to kind of stimulate those areas. But we have to figure out how that's going to work long-term for patients.
Yeah, in fact, it's a different concept. It's kind of twice a day for around 30 minutes, the patient is stimulated, but it's an extra canal. You go in the muscle, it's not inside the canal, the stimulation. And it seems good. To me, it looks like from the presentations I saw, that the key is, as you well mentioned, patient selection. They use also ultrasound-based algorithms to really select the patients that have muscle atrophy that will profit. But the results they're presenting, they seem promising. I think it's worth to take a look in the long term, as you mentioned.
Yeah, I mean, off-label, we've been using it that way for a while, and we'll use it in the paraspinal region. But again, we just don't have enough focused data on it as of today for me to say yes, I support it for sure.
Agreed. All right.
Yeah. Anyone else?
Dr. Price, great.
Hey, how's it going, Timmer?
Great presentation. Thank you so much. Could you please go over your weekly schedule just to give us an idea which days you see patients and when you do the procedures?
Sure. So I see patients every day, every Monday, every Friday, every Tuesday. I have procedure slots and OR time, and every other Wednesday. So basically any day except for Thursdays, the only days that I cannot do procedures. every other day. I can slide those patients in. And then clinic-wise, I also open up slots to see patients on Monday on a need basis. But Tuesday mornings, I have dedicated clinic time. Also all day Thursday when I'm in the UHealth Spine and Brain Clinic. And then the newly hired Luva Rodriguez, who's the nurse practitioner, she'll be seeing patients 5 days a week. So that's pretty much my schedule.
Thank you. And where do you do the procedures?
I do procedures at Medical Wellness Center or Clinical Research Building, Don Sofer Clinical Research Building. I do them at Lennar. I do them at Sylvester as well. And then I'll be going to Soleil Mead once that opens and to Doral also.
Wow, thank you.
Any other questions about anything? All right. Well, thank you guys for your time. Thank you guys for having me. It was a true pleasure. I enjoyed very much so working with you guys in the department and looking forward to working with you in the future. We do share a lot of patients, and I appreciate all the things that you do for my patients. I hope you guys appreciate the service that we provide for your patients as well.
Thanks again, Shanae.
Thank you guys. Have a good day.
Dalton, you want to introduce our next speaker?
Sure. Good morning, everyone. Great talk. Department of Neurological Surgery and the Miami Project is working really, really closely with physical medicine rehabilitation. So it was great to hear this presentation today. And we continue to build alliances with physical medicine rehabilitation as well as physical therapy over at the new Lens Center. So it's my pleasure this morning. Welcome to introduce Dr. Nadine Kerr. Dr. Kerr is a postdoctoral associate in the laboratory of Dr. Helen Bramman in the Miami Project, Department of Neurological Surgery. As you may know, for many, many years, we've been working with our neurosurgical colleagues and receiving blood samples from different types of patient populations, be it spinal cord injury, traumatic brain injury, and more recently, stroke. And in those studies, we've been assessing increased levels of a variety of pro-inflammatory mediators. And we've been using these as biomarkers to assess injury severity and ultimately how a patient does in the long term. But you have to ask the question, what are these circulating mediators doing, and what are the effects possibly not only on the brain injury itself, be it stroke or traumatic brain injury or spinal cord injury, but what's happening in terms of remote or organ systems. So that's a very exciting area, and Dr. Kerr has taken over this project for many, many years now. She received her PhD in the neuroscience graduate program here, and today she's going to give us some, I think, some clinically relevant information on the role of abnormal inflammasome signaling on multi-organ dysfunction after brain injury. Good morning, Nadine. Thanks for joining us.
Good morning, everyone. Thank you for having me. Let me just share my screen. So thank you for that introduction, Dr. Dietrich. Yeah, I've been here for a few years, did my PhD looking at inflammasome signaling and the effects that inflammasome signaling has on lung disorders after traumatic brain injury, and stayed for my postdoc, and I've been taking this over into stroke. So I'm really looking forward to sharing some of this work with you today. As I'm sure many of you know, multi-organ complications can occur after TBI, and about 89% of severe TBI patients suffer from some form of non-neurological organ complication. And these are patients without extracranial complications to begin with. So basically what happens after TBI, there's several things going on. We have some autonomic dysfunction, as well as systemic and neuroinflammation, which is what I'm going to talk about today. And after this, you see that there can be complications. All of these factors can lead to complications in remote organ systems, such as the respiratory system, the cardiovascular system, changes with bleeding, and changes to kidneys, which these are just to name a few. But then after this, we also can see then the increase of brain injury. So taking us into this new area of research of bidirectional axes between the remote organ systems and the brain. And our research interest and what sort of started me on this field was particularly with the changes in the lungs after traumatic brain injury. And that's mainly because cardiorespiratory complications are the most common after severe TBI. And the two that are most commonly seen are acute lung injury, ALI, or acute respiratory distress syndrome, ARDS. And about 25 to 30% of severe TBI patients develop ALI and ARDS. And another issue we see is neurogenic pulmonary edema, which is not as common, but can be very life-threatening. So in a study done several years ago, looking at the contributing factors to mortality, they looked at a group of patients, and of these patients that had a non-survivable TBI, 34% of the contributing factors was actually due to respiratory dysfunction. And here are two mechanisms which could explain how this happens. On the left side, it shows that after TBI, it leads to the stimulation of the adrenal glands and the release of epinephrine and norepinephrine, which leads to what is known as the catecholamine surge, and that can result in cardiac injury, to the constriction on vessels, and leading to an increased systemic vascular resistance and an increased blood pressure, then thus leading to neurogenic pulmonary edema. And then on the other hand, there's also the systemic inflammatory response, which is the area of our research, where after traumatic brain injury and disruption to the blood-brain barrier, we see the release of immune cells into the circulation, as well as pro-inflammatory cytokines and damage-associated molecular patterns, which then can activate innate immune pathways such as the inflammasome. And then this leads to acute lung injury and ARDS. But of course, in order to study this systemic inflammatory response, we should just quickly go over what goes on in the brain in relation to the innate immune system. So immediately after TBI, we see this increase in alarmins, which are the damage-associated molecular patterns or DAMPs, such as HMGB1, IL-33, ATP, mitochondrial DNA, just to name a few. And then these can activate the inflammasome. And after inflammasome activation, we see a release of IL-1 beta and IL-18. And then in the minutes to hours when we see the neutrophils arrive and then can stay up to several days after injury. And lastly, starting hours and in the days post-injury, we see monocytes and lymphocytes, which then continue to stay several weeks after injury. So the inflammasome is a multi-protein complex that activates caspase-1. And here there are different types of inflammasomes. These are the different inflammasome sensors: NLRP1, NLRC4, AIM2, pyrin, and NLRP3. And these are activated by the DAMPs, or extracellular ATP, RNA, DNA hybrids, and several other pathogens. So after these are activated, these inflammasome sensors, they bind to the adapter protein, which is known as apoptosis speck-like protein containing a caspase recruiting domain. Really long name, but it goes by ASC. And then that activates caspase-1. And then the active form of caspase-1 can then lead to the maturation of IL-1 beta from its pro form to its cleaved form. And caspase-1 can also lead to the cleavage of a protein known as gasdermin D. Gasdermin D is now more recently been studied because it leads to this pore formation in the cell membrane. And that is very important for this regulated form of cell death that's mediated by the inflammasome known as pyroptosis. And after this, we then see the release of IL-1 beta and IL-18. And pyroptosis, compared to other forms of cell death, such as apoptosis, which involves a series of tightly controlled events and membrane blebbing, where you see these apoptotic bodies and DNA condensation and fragmentation. Then, for example, non-programmed necrosis, which also is stimulated by external factors, where we also see this membrane rupture and cytoplasmic swelling. Pyroptosis, on the other hand, does have that pore formation through the inflammasome cascade, and that leads to membrane rupture and then the release of its intracellular contents. So the question is, how are these contents that are released from these cells then traveling to other cells into the circulation and then possibly causing this systemic organ damage? And one possibility, and an area that we've done extensive research, is through extracellular vesicles, or EVs. And these are cell-derived vesicles that are enclosed by a lipid bilayer. They're important mediators in cell-to-cell communication because they transfer proteins, lipids, and nucleic acids between cells. And they can be isolated from any bodily fluid, which makes them easy to study. And we isolate them specifically from serum for these studies, but also can be isolated from plasma, CSF, bronchoalveolar lavage fluids, and any fluid. And in 2018, we published a study where we examined inflammasome proteins in the serum and the serum-derived EVs of severe TBI patients. And this is a study we did with Dr. Bullock, and we collected serum from 22 severe TBI patients at Ryder Trauma Center. They had a GCS of 3 to 8. And we collected the serum for 5 days after TBI, 3 times a day. So here are some of our results where you can see that this protein, that adaptor protein ASC, was significantly increased in the serum of the TBI patients compared to control. And we're seeing this really in the first 2 days. That was when it was the most significant. In caspase 1, it seemed to really increase in the first day. And then we also saw this with ASC, that it was also increased in the TBI patients compared to control in the serum-derived extracellular vesicles. And also, this increase in ASC was correlated with unfavorable outcome in these patients. So making these inflammasome proteins in serum and the serum-derived EVs possible biomarkers for severe TBI. So we hypothesized then that these systemic EVs carrying inflammasome proteins are then being taken up by remote organ tissue. In this case, I was looking at the lungs. And in order to study this, I used a mouse model, a controlled cortical impact model. It was a severe CCI model, and we injured the mice and then collected tissue at 4 hours and 24 hours after CCI. And we picked these time points based on previous inflammasome research on TBI in our lab, as well as published studies on TBI and lung dysfunction, and just what we know clinically about acute lung injury in general after trauma. And as you can see in these Western blot images here, at 4 hours and 24 hours after TBI, we see an increase in the inflammasome proteins that I mentioned: ASC, caspase 1, IL-18, IL-1 beta, and AIM2, which is one of the inflammasome sensors, and HMGB1, which is one of the DAMPs that activates the inflammasome. And also, we wanted to look at cell specificity in the lungs for the inflammasome activation. So here in red, we stained for surfactant protein C, which is a type 2 alveolar epithelial cell marker. And these cells are very vulnerable to acute lung injury and ARDS. So this is why we stained for them. And then in the green, we stained for ASC. And as you can see, at both 4 hours and 24 hours, there's co-localization of ASC to these type 2 alveolar epithelial cells, so therefore evident that it is being expressed in these cells. We also then, to look at pyroptosis, we isolated a pyroptosome, which we can do, and where you see this ASC laddering, it's very important for pyroptosis. And as you can see here, we see an increase in the TBI of this. We see the presence of this ASC laddering and pyroptosome formation. And to further confirm that this is pyroptosis, we looked for gasdermin D expression, which was also increased in the TBI mice. And these samples were done at 24 hours after TBI. But to actually determine that this was acute lung injury, we did an acute lung injury scoring in the mice. So this scoring method it was created by the American Thoracic Society, particularly for studying ALI in rodents. And it's the characteristics that are used, and the rubric that we use for this scoring system is based on the same hallmark characteristics that they are seen in patients with ALI. So these are looking at neutrophils in the alveolar space, neutrophils in the interstitial space, formation of hyaline membranes and proteinaceous debris filling the air spaces, as well as alveolar septal thickening. And as you can see here, so the sham animals show this normal alveolar morphology, and you don't see infiltration of neutrophils into the alveoli. But in our 4-hour animals especially, you can see that there's a thickening of the interstitium. You can see the infiltration here of neutrophils into the interstitial space, as well as some alveolar neutrophil infiltration, which actually at 24 hours, you do see a little more of that. And so, yeah, we see that it's more drastic at 4 hours, but it definitely continues up to 24 hours. And when we actually did the scoring for this, we did see statistical significance compared to the sham mice. So now that we established that the inflammasome is involved in the development of ALI after TBI, we wanted to further study the mechanisms of how this was happening. And as I mentioned earlier, we were mainly interested in EVs. And in order to actually determine that EVs are involved in this pathway, we performed an adoptive transfer experiment. And in order to do this, we took serum-derived EVs, we isolated them from the serum of TBI mice and naive mice, and then we injected those vesicles into another group of naive mice. And there's in order to actually further prove that, we use these two treatments. One is enoxaparin, which is an EV uptake inhibitor. It has also shown to have anti-inflammatory properties, as it's a low molecular weight heparin that in some studies has been shown to reduce cerebral edema and enhance neurological recovery in TBI. And it's a low molecular weight heparin. One reason they use it is because of its anti-inflammatory properties, but heparin itself has been shown in culture studies to block the transfer of EVs between donor and recipient cells. And then another treatment that we used was an anti-ASC, which is a monoclonal antibody that blocks the polymerization of ASC, so that ASC laddering that I was showing you earlier, which thus blocks the assembly of the inflammasome and ultimately blocking the release of mature IL-1 beta or IL-18. And this, I know there's a lot on this slide, but if you look at these bar graphs here, the untreated mice are the mice that received the serum-derived EVs from the TBI into the naive, and they weren't given either enoxaparin or anti-ASC. So there you really see that just by delivering the serum-derived EVs of these injured mice into the non-injured mice, we have an increase in inflammasome expression, the same proteins that we looked at before: ASC, caspase-1, IL-1 beta, AIM2, and HMGB1. And then when we treated these mice with enoxaparin or anti-ASC, and this was given at 30 minutes after the injection, these EVs were injected intravenously through the tail vein. And we then injected the enoxaparin or anti-ASC 30 minutes after, and then collected the samples, the lung samples, 24 hours after. And then there was, with both enoxaparin and anti-ASC, we see a reduction of inflammasome protein expression. And looking here at the histological sections, with the untreated mice, you see that there is a change in the morphology similar to what we saw when looking at the ALI in the other mice. And then after treatment with both enoxaparin or anti-ASC, that these changes, we were seeing it looks more like the sham, more like a normal alveolar morphology, and less of the thickening of the interstitium that we saw before. And then so that was looking just in delivering the enoxaparin after the tail vein injection and after the adoptive transfer. But we also wanted to see if we just delivered the enoxaparin, and this was done at a low dose of 1 mg per kg, to see if it reduced inflammasome expression after severe TBI. And we delivered again 30 minutes after TBI, and then collected the brain and lung samples 1 day after. And we did see a change in the inflammasome expression reduction here compared to the untreated and the TBI vehicle mice. in both the cortical and lung tissue. We also saw that with the treatment of enoxaparin compared to here, so we have the sham mouse, the mice that received a vehicle, and then the enoxaparin treated mice. And as you can see with the enoxaparin treatment, the alveolar morphology and just the injury to the lungs looks much more like the shams, and it has a significantly reduced ALI score compared to the TBI vehicle. So that kind of touches over our work in TBI and lung injury, and the goal is to hopefully look into other organ systems. We're really interested in the GI system and in the heart and amongst other organs, but that's sort of summarizes what we've done in TBI and lung injury. And now I'll move on to some of our studies, more recent studies in stroke. So again, as I'm sure many of you know, stroke is a multi-organ disease in itself. It affects several other organ systems, including the endocrine system. There's also the involvement of the autonomic nervous system and the systemic damage, as we mentioned with the TBI, the urinary system, the cardiovascular system, and the immune system, of course, and then there's changes to the muscular system and skeletal system. But we're most interested in the respiratory system as well as the GI system. And in the respiratory system, some of the biggest complications that we are seeing, again, are ALI, ARDS, which develops in about 15% of stroke patients, and then pneumonia, dysphagia, venous thromboembolism, and neurogenic pulmonary edema. And then with the GI system, common disorders that are found are gut dysbiosis, gut dysmotility, fecal incontinence, GI bleeding, changes to the gut microbiome, leaky gut syndrome, and barrier disruption. And these are just to name some. So we did a similar study as we did with in the serum of TBI patients. We did a similar study with the serum of stroke patients. And so here, what we did was we looked at the serum and serum-derived EVs of stroke patients, and these samples were analyzed at 24 hours. And what we see was, again, an increase in ASC, especially. We looked at the other inflammasome proteins, but ASC seemed to give us the best results, where it's increased in the stroke, the serum and the serum-derived EVs of stroke patients. So again, that this inflammasome proteins, particularly the ASC, could be a potential biomarker. So we wanted to study this same hypothesis where we're looking at the serum-derived EVs and how they're taken up by other organs after stroke. And the model that we used for these studies is the photothrombotic stroke model. So this model was originally developed by Dr. Dietrich and Dr. Watson several years ago, and that was using a rodent model. So over the past couple of years, about a year and a half or so, we've been trying to create this model for mice in our lab, and we're using this YAG laser. This is a picture of the laser in our lab. And how this photothrombotic stroke works is that it aims to induce ischemic damage within a given cortical area by means of photoactivation of a previously injected light-sensitive dye, so here, which is rose bengal. And after illumination, the dye is activated and produces a change to endothelial cells, so endothelial damage through platelet aggregations and thrombosis, and eventually it disrupts the local blood flow. Here's a really nice EM image of that. And it's, for several reasons, it's really good to use because it's minimally invasive. You don't have to do a craniotomy, and it's very reproducible. So there's a well-defined localization of the ischemic region. And on top of that, the surgery does not take very long. So for moving on with data, it's very efficient. And this is just an example of what the infarct looks like here at 3 days after stroke. So we have this nice bowl-shaped lesion was what we were aiming for. And we also have an image here of 1 month after stroke. So we're doing some more studies to look into this, but you can definitely see that there's a progression of this infarct out to 1 month. And so far in this photothrombotic stroke model, there's not really much research regarding inflammasome signaling. So in order to really determine even that this model produces inflammasome activation, we did some studies looking at how this photothrombotic stroke induces inflammasome activation and if it leads to pyroptosis. And in order to do this, we did a time sequence to see what the time course of inflammasome activation was in this model. And we injured these mice, and so after we irradiate these mice after the rose bengal injection for 9 minutes. And we tested several different parameters, and this seemed to be what gave us the lesion that we were looking for. And we collected the mice tissue at 1 day, 3 days, and 7 days after stroke. And as you can see here, there's a significant increase in caspase-1, ASC, IL-1 beta, the inflammasome sensor, NLRP3, which has been widely studied in stroke, and gasdermin D, which was the protein that's necessary for that pore formation and for pyroptosis. Here, it is increased, probably this most significant increase is at 1 day, but does continue at 3 days and 7 days. It starts to come down a bit after the injury. And to look at which cells were involved, we have right now just looked at neurons. Our plan is to look more into microglia. We've seen that there is an increase in microglia activation, but to look at the pyroptosis, we saw that in neurons after this immunohistochemical stain here. In red, we stained for NUN, and in green for gasdermin D. And you can see, and this section we sectioned this at 24 hours after the injury. And there's this colocalization again, so indicating that there is some neuronal pyroptosis that is occurring 24 hours after our photothrombotic stroke. And we've done some preliminary data, just looking initially at what happens in the lungs with this model. So again, in the same mice, what's great about the way we've worked out doing our perfusions and collecting all the tissue is that we're able to fix the tissue from the same mice to reduce variability. So in the lungs of these mice, we again did the time course where we looked at 1 day, 3 days, and 7 days after injury, and saw the most significant increase in the inflammasome proteins at 1 day after stroke. And then interestingly, it seems to, in the lungs, come down a bit at 3 days, but then increase again at 7 days, 7 days after injury. And these lung sections were taken at 24 hours after stroke. And in the sham, you see similar to the TBI mice where there's a healthier morphology. In the stroke, there are, again, some of the same characteristics as ALI, but we do not see the same infiltration of neutrophils into the alveoli. There's definitely a change in the alveolar morphology, and a very drastic, here you can see that there's a thickening of the interstitium, and it seems like several of the inflammatory cells are actually in this interstitial space. So we'd hope to do some more in-depth studies to see what kind of lung injury this is causing, if it is ALI, ARDS, or that there's something else going on, and we'd really like to look more into that. And then we did, to look at lung function, we did a wet to dry weight ratio, which looks at the changes in lung permeability. And the lungs of the stroke mice were more permeable, which is what we would expect. So hopefully in the future, we'll continue to work on this, looking into these changes in the lungs after our stroke, in our stroke model. Our other big area of interest in this model is in the gut. And as I'm sure everyone's probably heard, this bidirectional gut-brain axis is a really hot topic and cool area of research right now. And it involves several different systems: the autonomic nervous system, the enteric nervous system, endocrine system, the HPA axis, and the immune system, which is what we're studying, and the microbiota. As far as inflammasome signaling goes, the role of the inflammasome in the bidirectional gut-brain axis has been studied in multiple sclerosis, Alzheimer's disease, Parkinson's disease, as well as neuropsychiatric disorders, but it has not really been studied as far as the inflammasome goes in a CNS injury. So here, it's just a nice schematic which shows that there's changes after in a disease state, there's changes in, disease state in the brain, there's changes in the intestines, and we have some important cells that are part of the enteric nervous system. And then these release inflammasome proteins. And then again, also seeing the damage in the brain cells, particularly microglia and in neurons. And then, so the combination of the release of these inflammasome proteins into the circulation will contribute to this bidirectional access. So our hypothesis was that after stroke, there's inflammasome activation due to the changes in the blood-brain barrier, and then this leads to an increase of inflammasome proteins into the circulation, and that then these inflammasome proteins, that increase is causing changes to gut permeability, and then the increase of the gut permeability will then further increase the systemic inflammasome protein and gasdermin D expression due to pyroptosis, and then that can further that can lead to increased neuroinflammation and worsen neurological function. Because I think clinically, as far as stroke patients that develop GI symptoms, they are seen to have worsened neurological function than those that don't. So that would be going along with this bidirectional axis. And so in the same mice, we also collected these intestines, the small intestines here, and we looked at this time course where at 1 day, 3 days, and 7 days after our stroke, there was an increase. Again, it seems like consistent that the most significant increase in these remote organ tissues is at 24 hours, but does continue up to 7 days, especially with caspase-1 and ASC. Gasdermin D expression, which is for pyroptosis, seems to be the highest at 24 hours and then seems to decrease at 3 days and 7 days after stroke. Our stroke model also induced morphological changes in the intestines. These were sections that were taken again at 24 hours after stroke. And as you can see here in the sham, there's this healthy looking morphology, especially with the microvilli, where they have the finger-like shape, and you do not see this as many inflammatory cells as we do here in the stroke mice. There's this large increase in influx of inflammatory cells, and the shape of the microvilli is clearly not the same, where we don't have the same healthy finger-like shape. There's more of these wave-like shapes where the microvilli look distorted. And to look at the permeability in the gut, we inject FITC dextran, which is fluorescent, and it is non-digestible normally. It's 4 kilodalton protein that's non-digestible. So when there's increased gut permeability, you will have a higher fluorescence of it. And that we did see that in our stroke mice, where we saw an increase in the permeability in the stroke mice compared to the sham mice. So all of this is pretty exciting, and we're hoping to look further into this. These are just studies that have just started over the past year and a half or so. And in summary, so here's again our model where after brain injury, whether it be TBI or stroke, we lead to an increase in EVs containing inflammasome proteins. And then that affects the gut increased permeability and just dysfunction of remote organ systems. In our case here, we've only looked at the gut and the lungs. And then there's also an increase in pyroptosis. So the changes to the function and permeability of these remote organs will then further increase the release of EVs containing inflammasome proteins. And then this, we think, is contributing to this bidirectional axis. And we've also saw now that inflammasome proteins that are in serum and serum-derived EVs can serve as biomarkers for TBI and stroke, and that inflammasome signaling and apoptotic cell death plays a role in the development of ALI and ARDS after TBI patients, and that this both inflammasome signaling and the apoptotic cell death as a result of that are involved in the bidirectional gut-brain axis and lung-brain axis as well. And then when we treat these mice and in our models with this enoxaparin or anti-ASC, so an EV uptake inhibitor being enoxaparin and an inflammasome inhibitor, which was anti-ASC that we studied, there's we see and we hope that by doing this, there's a decrease in inflammasome activation in the brain as well as in the remote organ systems, thus decreasing pyroptosis and cell death in the distal organs and the brain. And we hope that with treatments with such therapeutic agents can lead to decreased GI and lung complications after brain injury. And so some future directions and that we hope to go with this. We've only studied enoxaparin and anti-ASC in our TBI studies, and we'd like to also look at those in our stroke studies and also in our TBI studies with other organ systems. And then there's also would be interesting for us to look at, so we've looked at the communication between the brain and the other organ systems, but recently I've been seeing more research about, for example, a lung-gut axis. So how all these organs are working together and contributing to this systemic damage. And then, for example, in the lungs, we've looked mainly at the lower lung, the lung injury, but not at upper respiratory complications, which I know is common in TBI and stroke patients. So that's something else we'd like to look at. And another question that often comes up with this research is these extracellular vesicles, are they actually coming from the brain or where are they derived from? So that's something that is very important to our work and that we're going to look into to see if these EVs are after brain injury, are they coming from the brain and are they coming from the lungs or the intestines? So that's something important we hope to see. And also continue to look at the types of cells in the lungs and intestines that are undergoing pyroptosis. And then hopefully down the line, how any of these treatments with some rehabilitative support or other supportive treatments can be useful to reducing remote organ damage after brain injury. And I'd like to thank my postdoc mentors, Dr. Bramler and Dr. Dietrich, everyone in our lab. And we, some of the work in the beginning was done with my previous PhD mentor, Dr. Keen. So just, yeah, it's exciting. Thank you. I hope any questions.
Yeah, thank you very much for that very excellent talk. Yeah, Nadine and colleagues have really opened up a new chapter in our research looking at these remote effects. And, you know, when you start throwing out words like transport of exosomes and extracellular vesicles in the remote area, it really opens a really great area of investigation with neurosurgical colleagues. Right now, of course, we've been working with Bobby Starks in terms of the stroke work that we're doing, Kevin Wang in terms of spinal cord injury, and Joe Casoli and Jonathan Jagan in the TBI currently. So we're really interacting with the Department of Neurological Surgery a lot. And we think that, you know, especially with enoxaparin, and there may be an opportunity for a clinical trial, just one dose, trying to reduce the effects of inflammasome signaling on both the injured brain or spinal cord as well as remote areas. So anyway, exciting work, and Nadine has really done an excellent job. Really excited about the gut brain axis. I mean, that just opens up a lot of opportunities for research. So residents and anyone interested in the topic that we talked about today, please contact ourselves. Of course, this is a collaboration with Robert Keene, Physiology, Biophysics, Pablo Di Rivero, Vicari, Miami Project Neurosurgery, and of course, Helen Bramlett. So anyway, open up for questions. Any questions for Nadine, please?
Hey, Nadine. This is Shelby. Can you hear me?
And hi, Shelby.
Hey, thanks for the talk. Yeah, we were looking at, we were trying to do some exosome stuff, also Schwann cell-derived exosomes, and I'm just getting acquainted with different terms, EV, exosome. How do you kind of isolate them from serum in patients and rats or mice?
So thanks. Yeah, thanks for asking. And again, thank you helped us a lot with the collection of the studies that we showed here. So it's with the collecting them from the patients. And so we actually, there's several different methods. The first original method, which for a while was kind of considered the gold standard, was this ultracentrifugation method. And but that took several hours, almost a day, or for however many samples you could fit in the centrifuge. So that's not so clinically relevant. And since then, there's been just more like kits and other ways that bead associated isolations that make it a lot more time efficient. The one that we used for these studies is it's from a kit, but it uses polyethylene glycol, and it does sort of a density gradient isolation. And we usually have results or isolations in about 2 hours. And it's been pretty efficient for us. And it's very commonly seen in research. We did a study early on where we compared the 3 different types of methods using a few different kits and ultracentrifugation. And this one seemed to work the best for us.
Cool. Is there any value to try to image these, or are they too small? Is that not something that could be done?
It would be great if we could. I mean, they are very small. So the best way is using EM. If just using regular confocal microscopy, we can't see it. There's I didn't show this slide, but at DRI, they have a nanocyte machine, which just helps you, once you've isolated them, you can check to make sure that they're the right size as well. So that you have your population are in are actually extracellular vesicles. And imaging them would be great, but the best way to do that would be with EM.
Okay.
Just say we just started working with some radiochemists for PET studies, where we can actually potentially move some of these studies to imaging patients to actually look at the effects of these inflammatory mediators, not so much at the cellular level, but in terms of the regional changes that are occurring. So that's an exciting area for us as well. Ami, do you have a question?
Yeah, Nadine, it was an excellent talk. One quick question. I'm more interested in your stroke and lung and gut axis studies. And did you do any of this experiment using both the sexes of animals? And did you see any sex differences there?
So we did use, we always try to use an equal number of males and females in these studies. I haven't done I haven't actually looked at the gender difference in these, sex difference in these studies yet, but I will. That's a very good and relevant question. And I'm planning on doing that because definitely I know with stroke, that's extremely important. So, and we are, right now, most of these studies were done in younger mice. So that was another thing I was wanting to mention, should have mentioned in the future directions, that we hope to look at this in aged mice as well.
Excellent, thank you.
Thank you.
Just say Ami Ravel is someone maybe you don't know, Dr. Ami Ravel. She's in the Department of Neurology, and she'll be actually moving over to Lois Pope Life Center and collaborating with us very closely. So some of the questions that Ami is currently addressing, such as stroke and cigarette smoking, we're going to try to integrate into some of our studies. So very exciting times, and looking forward for Ami to come over. Other questions? Okay. Nadine, thanks again for a wonderful talk, and I hope everyone has a fantastic day.
Okay.
Take care. Bye-bye.
Bye-bye.